Auzu billahi minash shaitanir rajim. Bismillahir Rahmanir Rahim. I am Professor Dr. Sarfraz Hussain Sayyed, Professor of Ophthalmology and Head of Eye Unit 2, Punjab Medical College, Faistabad Medical University, Faistabad, Punjab, Pakistan. Today we are going to discuss the fungal keratitis. It is classified mainly into two classes, filamentous and yeast. The major species in filamentous fungi are Aspergillus, Fusarium solani, and Scedosporium. These are multicellular. They produce tubular projections called hyphae. These are most common in the tropical climates. The yeast, the major part of yeast is formed by the Candida species. It is an ovoid unicellular reproduced by budding and may produce hyphae or pseudohyphae. They are responsible for cases in temperate climates. The fungal keratitis is a rare in temperate climates but major cause of visual loss in the tropical and developing countries. The major risk factors are trauma with vegetable matter during working in the agriculture fields, chronic ocular surface disease and epithelial defects, diabetes, corneal surgery like penetrating keratoplasty or radial keratotomy, chronic keratitis like herpes simplex, herpes zoster, vernal keratoconjunctivitis, allergic keratoconjunctivitis. It is also associated more with the hydrophilic contact lenses and the patients who are on systemic immunosuppressions. Patients present with initially a vague symptoms like irritation, light sensitivity, later having blurred vision and discharge. Usually there is a history of trauma or the other major risk factors. Initially, there are fewer inflammatory signs of redness, conjunctival hyperemia, and the signs vary with the infectious agents. With Candida keratitis, there is a yellow-white infiltrate associated with dense suppuration. This is a patient who has had a penetrating keratoplasty and developed an infection with Candida species. Filamentous fungal keratitis appear as superficial lesions, gray-white, and elevate the surface of the cornea. Has irregular feathery appearance with filamentous margins which are dry, rough, or give gritty sensation at time of scraping. Occasionally, there are multifocal or satellite infiltrates. Here you can see these satellite infiltrate in this case. As keratitis progresses, there is intense suppuration like bacterial keratitis. It may rapidly progress and there may be hypopyon formation. You can see hypopyon in this case, as well as you can see the hypopan very clearly in this. And there are anterior chamber inflammatory membranes. The These membranes may extend into the anterior chamber and invade the iris and posterior chamber with the fungus. And secondary angle closure glaucoma may develop from the inflammatory pupillary block. The lab investigations required are the smear formation for microscopic examination, and that is performed by scraping either with the platinum chimera spatula or sterile hypodermic needle. The surgical blade can also be used. We can take the swabs for culture, and these swabs usually have thioglycolate moistened, or they may be formed by the calcium alginate or dacron. These may be used for smear onto the slide for chemical staining, or they also are used for the culture on the culture media. The gram staining is for candida, gomori, methanamine silver for the fungal cell walls. Here you can see the gram staining, and you can see the pseudo hyphae of the candida which appear black on staining. This is Grocott hexamine silver for aspergillus, in which you can see the hyphae of this fungi here, which usually have a branching pattern, if you can see the branches from there. The culture media for fungi are blood agar, sabarods, dextrose agar, brain heart infusion broth. We can also take the corneal biopsy by a small 2 to 3 millimeter trephine, or disposable dermatologic skin punch can be used to create a partial thickness incision, and forceps and scissors are used to excise a lamellar flap of the cornea. It is split into two pieces to evaluate for histopathology and microbiology. PAS stain and Grocott silver stains are most sensitive for the histopathological examination and staining. PCR is very effective, very sensitive, and reliable for the detection of fungus and the type of the fungus causing the keratitis. The management of keratitis is by use of antifungal agents. Initially, the epithelium is removed, and there may be superficial keratectomy required. The antifungals initially 1 hourly for 48 hours. Later, it is reduced in frequency according to the response. It has to be carried over for many weeks to avoid the recurrence. The filamentous keratitis The netamycin 5% suspension, iconazole 1%, miconazole 1%, amphotericin B 0.15% to 0.3% may be used. In Candida infections, iconazole 1%, netamycin 5%, fluconazole 2%, amphotericin B 0.15%, and clotrimazole 1%. Suspensions may also be used for Candida infections. The broad spectrum antibiotics should also be used to decrease the superadded infections or treat the superadded infection, bacterial infections. Subconjunctival antifungal fluconazole has to be used in case of hypopion. Intrastromal injections of antifungals like fluconazole or amphotericin B may also be used. These are infiltrated around the fungal ulcer. Anterior chamber lavage with amphotericin B and fluconazole in a very low concentration is used in case of hypopion and suspected endophthalmitis. Systemic oral ketoconazole 200 to 600 milligram per day in two divided doses for filamentous keratitis. Oral fluconazole 200 to 400 milligram per day for yeast. Oral itraconazole 200 milligram per day for broad spectrum activity can be prescribed. When there is, in case of unresponsive and threatening cases for very poor prognosis, we can also use a therapeutic penetrating keratoplasty in which we use a large graft. Like here we see the graft is large, which is used for the treatment and management of imminent perforation in case of fungal keratitis. Thank you very much.